Thank you for this kind introduction, and I think this is a nice transition from the realm of big data to the realm of no data, but I think maybe it's not as bad. Let's see what we can say about the topic of heart failure treatment in congenital heart disease. I have no conflicts of interest to declare. Now, of course, there is, and everybody in the room knows that there is a big burden of heart failure in the congenital patients, and it's as these patients get older and develop complications, heart failure emerges as one of the major reasons for death in this population, according to the publications. And we will have to speak about how we define heart failure, but it is clear from the literature that heart failure is a major cause of mortality in this population. We also appreciate that our patients get more complex, that our patients get older these days, and with the older age, the spectrum of disease that we encounter changes in this patients, and this is shown by the study from Brompton, showing an increase in the number of patients over the age of 60s who presented to the service. And again, from data from the Brompton, we appreciate that with the increasing age of the patients, heart failure mortality becomes by far the most predominant cause of death. Sudden cardiac death and other forms of modes of death remain an issue, but with this aging and more complex population, there will be probably an epidemic of heart failure coming our way. So there is certainly a clinical need to talk about heart failure and about the treatment of heart failure. But before we come to talking about the treatment of heart failure, I think we have to establish what is heart failure. And there are multiple definitions of heart failure in the literature, and the one that I favor is this one given by the late Philip Poole Wilson in 1985, and he defined heart failure as a clinical syndrome caused by an abnormality of the heart and recognized by a characteristic pattern of hemodynamic, renal, neural, and hormonal responses. So a very broad definition of heart failure. And if you look into our patients and apply these definitions, then I think we can get an idea whether these patients have heart failure and whether we can apply the general principles of treatment. Well, one thing is clear. It doesn't affect all of our patients, but especially in very important subgroups, such as the patient with systemic right ventricle or the univentricular heart patients, signs and symptoms of heart failure, as conventionally defined, edema, shortness of breath, etc., are very prevalent. This is a study from Toronto 20 years ago almost, but it shows that with age, almost half of the Fontan patients and at least a third of the systemic right ventricle patients will develop signs and symptoms of heart failure. So the symptoms are there, the signs are there. One of the main features of heart failure and acquired heart disease has been defined as reduced exercise tolerance. So if you measure peak oxygen uptake in these patients with non-congenital heart failure, these patients have reduced exercise capacity, and there's a clear correlation between lower peak oxygen uptake and increased mortality in these patients. And in fact, the same is true for our congenital patients. There are multiple publications on that. This is one example that we published some time ago. There is also across the spectrum of adult congenital heart disease patients, there is an association between lower exercise capacity and increasing mortality, actually matching what we see in non-congenital patients. There's also neurohormonal activation in our congenital patients. All sorts of biomarkers are elevated, and the Dutch group here from Rotterdam have shown very nicely, again, an association between elevated biomarkers and lower mortality. Again, a feature that we are quite familiar with in non-congenital heart failure. And there are more publications to highlight the same issue, the association between elevated BMP values and increasing mortality in our population. And the same is surprisingly true for immune inflammation, which is also a recognized feature of heart failure. And there is data to show that our patients with congenital heart disease have higher level of TNF-alpha, interleukins, and other forms of inflammation. So there is a similar pathophysiologic response, including autonomic dysfunction, which is one of the main features of heart failure in the non-congenital section and is related to sudden cardiac death. And again, if we look at the conventional markers of autonomic dysfunction, heart rate variability, for example, or recovery of heart rate at the end of exercise, we also find signs of autonomic dysfunction in our patients. So the physiology seems to be relatively similar. Our patients broadly fit the definition that was given by Paul Wilson, and I've shown you a couple of slides before, and they also have similar features as do patients with non-congenital heart failure. So it would be very tempting to actually apply the data from the non-congenital patients and apply the same treatment principles. And as you are well aware, we have a high level of evidence for using medication in the non-congenital heart failure patients. So this is, of course, very tempting. But if you look at the current guidelines for heart failure by the European Society of Cardiology, for example, then you might realize that, when they define heart failure with reduced ejection fraction, they speak about left ventricular ejection fraction. So they speak specifically about the left ventricle. And what they most likely mean is the morphologically left ventricle. So I think there are issues here. So there is this recognized similarity between our patients in pathophysiologic terms with the non-congenital heart failure patients. They have heart disease, they have signs and symptoms, they have neurohormonal activation, etc. And some have proposed that this is actually maybe the original heart failure syndrome that we're dealing with. But there are also important differences when we look at our patients. We are quite commonly presented with patients that have a failing right ventricle, and as you know, the anatomy of the right ventricle is very different from the left ventricle. The tricuspid valve that supports the right ventricle is very different from the mitral valve. It doesn't have this hinge apparatus that the mitral valve has. The right ventricle is normally supplied by only one coronary artery, not by two, and there are other issues in our patients. If you think about Fontan patients with hepatic disease, with liver disease, with renal disease. So the pathophysiology is also different, and that brings with it a therapeutic dilemma. So is it similar to a non-congenital heart failure, or is it not similar? And I think this is actually the challenge that we are faced with. The other thing in terms of pathophysiology that we should not forget in our patients is that we quite commonly deal with preload problems to the ventricle in our setting, and this may lead to heart failure signs and symptoms and has important therapeutic considerations. So in conventional heart failure patients, what we have is we have a failing left ventricle. So this ventricle is not able to supply an adequate stroke volume to the circulation. And this ventricle actually has an unlimited preload. And if anything, the patient is fluid overloaded. So the preload is not the problem, the ventricle is the problem. But if you think, for example, about a Fontan patient with increased pulmonary vascular resistance, the ventricle may work very well, but it's actually the preload that determines the output of this ventricle. And of course, one may imagine, or one may believe that if you reduce systemic vascular resistance, it may help these patients very little if the problem is situated here and not there, or not in the ventricle. So there are important pathophysiologic differences. And so it may come as no surprise that if you look at the limited evidence that we have in the literature on the use of various heart failure medications, that the results have been quite mixed in this population. This is an early study on ACE inhibitors in patients with a systemic right ventricle, and as you can see from the p-values here, nothing has really changed with the treatment in these patients, but one may want to emphasize, of course, that the number of patients is very low. It's only 14 patients, and the follow-up is very short, and the endpoints are very weak as well. So there are methodological issues, of course, again with these studies. A very elegant study that has been published in 2013 from the colleagues in the Netherlands is a multi-center, double-blind, randomized controlled trials in patients with systemic right ventricle, and they used valsartan in these patients. And what they did is a very clever study design recognizes that a conventional mortality endpoint may not work in these patients. They focused on right ventricular ejection fraction on MRI, so they had a very meticulous assessment of these patients at the start of the treatment, at the end of the treatment with MRI, and treated them with either valsartan or placebo. And the event-free survival was not different between the groups, but that is not a main concern because that was not the primary endpoint of the study. But if you look at the change in right ventricular ejection fraction, there was little evidence of an improvement. So one conclusion of this study could be that the study does not support the habitual use of ACE inhibitors or ARBs in patients with a systemic right ventricle, especially in the asymptomatic ones. And the reason for this conclusion was that when there was a post-hoc sub-analysis of these groups, there was a trend maybe that the symptomatic patients may increase their ejection fraction in this group. So this is a very statistically, of course, a slightly difficult approach to take because this is not controlled for, and there may be some bias in here, but there is a clear signal here that maybe the symptomatic patients may benefit from this. Another very elegant study, and I think there's a lot of pathophysiologic rationale to test mineralocorticoid receptor antagonists in our patients with systemic right ventricle or congenital heart disease, because these drugs also have an impact on fibrosis, which is quite prevalent in our patients. This is a Spanish study where they tested eplerenone in patients with systemic right ventricle. And again, if you look at the primary endpoint, is an MRI-based right ventricular mass endpoint, and the secondary endpoint is right ventricular ejection fraction. And unfortunately, again, this study was a neutral study, so it didn't show an improvement with treatment in these patients. But again, if you read the study carefully, one has to realize the authors used only surrogate endpoints. There was unfortunately no industry support to run this study, so the study couldn't be as big as required. If you look at the power calculations that are supplied, they calculated that they needed 78 patients, 39 patients per study arm, and they screened over 110 patients, but they could only randomize 26 patients. So the study was, in the end, underpowered again, which maybe in part explains this neutral result in these patients. So what do we do with these results? Well, one approach would be to pool the results of various studies, and the American colleagues have attempted this. This is a systematic review that was published in Circulation this year as part of the development of the US-American guidelines. It's an interesting approach. Of course, meta-analysis are of great help in our work, but then if you look at this, they included only 3 trials in this meta-analysis, and then, of course, there's little surprise that the effect was negative if you can't expect to include 3 small trials and then something magic happens and you get a huge and highly statistically significant result. So this was, I think, more of an academic undertaking than a really useful clinical study, but it enforces what I've just said. Is the studies are small, they're underpowered, they don't provide clear evidence on where to go. And this is actually quite well reflected in the data. This is a slightly older study, a very interesting approach. Basically, what the authors of this study did, they went to several North American centers and asked them about their use of various drugs in patients with Fontan circulation. So the color coding here is different centers. And as you can see, there is a huge variability in what percentage of patients with Fontan circulation were on antithrombotics, on ACE inhibitors, on cardiac glucosides, on diuretic. And it basically just reflects the lack of data. So there's a lot of local practice that is applied here. So, it's of course, it's of little help for everybody in the room just to say we have no evidence and we just don't know what to do. There is, however, some guidance on how to treat this patient, and I think a good starting point is the recommendation paper that Werner Butz published in the European Heart Journal a couple of years ago, where they actually provide some recommendation on how to treat patients with congenital heart disease and heart failure with medical therapy. And if you go through this recommendation, I think it's quite helpful. So one good point to start, of course, is if you have a patient with a systemic left ventricle and a reduced left ventricular ejection fraction, for example, a coarctation patient or a patient with another form of congenital heart disease who develops this condition, it is very reasonable to apply all the data that we have from non-congenital heart failure. So to treat these patients proactively with ACE inhibitors, beta blockers, MRAs, diuretics, you name it. So I think this is a very straightforward group where we should apply the heart failure paradigm, and we should treat these patients proactively with heart failure medication. When we talk about systemic right ventricle, it all becomes a little bit more difficult. I've shown you this in the previous study. There may be a rationale to distinguish between asymptomatic and symptomatic patients, but I think it makes a lot of sense to especially those patients who have a reduced right ventricular ejection fraction, and you can well argue about the 40%. I think this comes, I don't know where it comes from, but I think if you have a reduced right ventricular function, if you have a symptomatic patient with systemic right ventricle, it makes a lot of sense to treat him with heart failure medication. In the asymptomatic patient, it's a little bit more open to discussion, but also these patients, if they have a reduced systemic ventricular function, they may benefit from this treatment. So I think this is a reasonable recommendation to make and probably useful starting point. In the patient with a univentricular heart, like this patient with a tricuspid atresia, of course, it's even more difficult. But again, if the univentricular heart is a morphologically left ventricle, if the patient is symptomatic, if you have signs of left or ventricular dysfunction, it makes in most patients probably sense to treat these patients with heart failure medication. If the patient have a morphological right ventricle, it may be more debatable, but I think in general these are reasonable recommendations to make for medical treatment, based, of course, on the limited data that we have. And the other thing that we should accept from the non-congenital heart failure guidelines really is, and I think this is very important for our patients, is if we embark on medical therapy, we have to up-titrate it appropriately, we have to reassess the patients, we have to see whether our treatment makes a difference. If it doesn't make a difference, we have to combine treatment, we have to escalate treatment, and we have to use devices if medical treatment fails. Just a few words on cardiac resynchronization therapy and assist devices, which I think are becoming more and more relevant to our field. Cardiac resynchronization therapy is one of the main treatment modalities in non-congenital patients, and it may have some value in selected patients with congenital heart disease. A number of years ago, we looked at the Brompton population, and just applying this non-congenital criteria at the time, we just wanted to know how many congenital heart disease patients actually would fulfill conventional CRT criteria. And what we found is that almost 10% of these patients with systemic right ventricle, univentricular hearts, for example, they broadly fulfill this criteria. So there may be a role of CRT in selected patients. But when we look at the current practice, and there was a study by the National Registry for Congenital Heart Disease in Germany where we looked at the use of CRT devices in congenital heart disease, what we find is actually a slightly different picture. First of all, it's only a limited number of patients who have been treated with a CRT device anyway. And out of this 65 patients with a CRT device, the majority of them had other indications for pacing. So they had bradycardia indications for pacing, and only a small minority of patients actually received a CRT device purely for heart failure indications. So it is a bit of a specific treatment reserved for very selected patients, mainly maybe for the CCTGA patient with a systemic right ventricle, some selected fallow patients. And you could argue that a coarctation patient with dilated cardiomyopathy actually fits the general recommendations for pacing. And I think the majority of patients really that receive CRT devices in the current era really receive it, such as this patient who was upgraded from a non-CRT device that led to a failing right ventricle in a CCTGA situation, and then when this patient was upgraded, there was an improvement. Well, there was a reduction in heart size and some improvement in right ventricular function. So there may be a role for CRT devices in selected patients. What about end-stage heart failure? Just a very brief comment on that, on assist devices, on transplantation. Of course, the data is limited, mostly anecdotal evidence. This is one of our patients with a failing mustard operation. This patient presented with severe heart failure, cardiac decompensation, NIH class 3 to 4. Conservative treatment failed in this patient. We even had to apply a pulmonary vasodilators to this patient because her pulmonary vascular resistance went up and she was not eligible for transplantation. But that recovered luckily in this patient, and you can see this is you could see if it would play, but this is a reduced right ventricular function. There were no other issues here with this patient, and unfortunately, when this patient crashed on ITU, our surgeons had to implant a assist device system, and the patient was transplanted ultimately from this assist device system, but she spent almost a year in hospital after that, had renal dysfunction, had polyneuropathic changes. So a very difficult and stormy postoperative course. But I think this is something to keep in mind, and many of our patients, I guess, will go down this assist device route in the future. Transplantation, we've been speaking about this the whole morning, and there have been excellent talks on that, and I don't want to repeat what has been said, but the issue remains. Again, there is relatively high early mortality in congenital heart disease patients. This is the red curve. But once these patients survive the perioperative course of transplantation, their long-term survival is actually quite good. Maybe one reason for optimism or signals for optimism, there is data to suggest that if you specialize on this, if you invest into transplant for congenital heart disease patients, there is potential to bring down this early mortality. So I think this is something where us as a community needs to work on to maybe improve the early outcome of transplantation, and then these patients will have a decent long-term survival. So just to wrap this up a bit, I think many of our patients do have heart failure, and broadly this heart failure fits the definition that has been provided in the literature for non-congenital heart failure. And if you look at the treatment paradigm of our heart failure colleagues who deal mainly with dilated and ischemic cardiomyopathy, this is their approach. So basically, the main treatment option is heart failure medication. This is the cornerstone of therapy, and if this fails, then they add devices, CRT devices, for example, or some sort of intervention. And if this fails, then they go down the assist device or the transplantation route. And I think for our patients, this whole pyramid is actually swapped around. It stands on its tip. So I think the most important part in our patients with congenital heart disease is to properly assess these patients when they present with heart failure. Quite often there is a structural problem that can be addressed, so we need an invasive diagnostic. We need to make sure that the plumbing is right and the hemodynamics is as optimal as can be for the condition. And then we need to worry about the cardiac rhythm, because we know that our patients don't tolerate arrhythmias very well, and many patients, especially those with reduced function or univentricular hearts, they don't even tolerate supraventricular arrhythmias very well, so they need a proper electrophysiology workup, and we should not rely on antiarrhythmics. I think these are the patients where electrophysiology really comes first, and this is supported by the new ESC guidelines for supraventricular tachycardia. Electrophysiology should come first in these patients, and then we need to think about devices. And if all of this fails, then I think heart failure medication has an important role. You can apply it, of course, even earlier in this diagnostic or treatment pyramid, but these things, I think, are very important for our patients to identify comorbidities, to identify structural problems, to deal with the rhythm as well, and then think about heart failure medication. And of course, there are end-of-life issues as well in some of our patients. Just to illustrate the point, this is a patient that Anselm Übing treated when he was at the Brompton doing the interventions there. This is a patient with a classical Fontan operated by Professor Sir Magdi Yacoub a couple of decades ago, and this patient had valved conduits in his classical Fontan, and of course over the years these valved conduits degenerated and calcified, and the patient presented with very severe heart failure. As you can see here, the obstruction in the pathway of this Fontan, and of course this patient was very much in trouble. And I think everybody in the room would accept that it doesn't help this patient much to throw ACE inhibitors at him. You have to deal with the structural problem first, and then as a second step, you of course can think about heart failure medication. So I think this is just to underline this important issue. So just to conclude, I think it's pretty clear from the data that heart failure is common in congenital heart disease patients, and it's increasing with age, and unfortunately is increasingly becoming an epidemic and limiting life expectancy in our patients. It's associated with considerable morbidity and loss of quality of life, of course, in these patients as well. Unfortunately, our treatment options to date are limited. Frequently, we have to rely on a pragmatic approach rather than on an evidence-based approach. And I think all these patients need an individual assessment. We need to exclude structural or electrical problems as a causative factor. And if we've done this, then I think in selected patients, a proactive approach with medication is warranted, but we should not forget, as patients deteriorate, to list them for transplantation and to apply assist devices in a timely fashion in these patients to avoid catastrophic outcome in these patients. Thank you very much.